Welcome all of you to our first, but hopefully not last, MSW RA Research Symposium. Many of you I know, but for those of you who I haven't been able to meet, my name is Liz Matthews. I'm an assistant professor here at Fordham GSS. I teach primarily in the practice with individuals and families domain. Some of you I have seen in class. I'm sure I will see more of you in class. But most recently this year, I was given the opportunity to kind of take the helm of the RA program that is organized by the Committee for the Advancement of Research and Scholarship here at GSS. So as part of that, we are very excited to host this inaugural MSW RA Research Symposium for us to be able to showcase some of the great work that is being done by the students at GSS. So as many of you may know, and some of you may not know, we already have a really robust program of research assistants here at GSS. So this year alone, we had over 22 MSW students that are working with faculty members at GSS on a variety of research projects. And what we began to hear from students is that there's a real interest in having more opportunities to talk about research, to share research, and to really learn about social work research. So we heard this, and we're excited to take this first but not last step towards creating a space and really building a community for students that are interested in different facets of social work research. But more than that, we have a wonderful group of RAs that have worked really hard amid a very strange and challenging year. And so we're really excited to be able to showcase their efforts this evening. I also want to extend a thank you to all of the faculty that have mentored RAs, including those who are presenting this evening. So a special thanks tonight in particular to Doctors Abby Ross, Larry Farmer, Marciana Popescu, Rabel Rahman, and Jordan DeVeiler. If there are many squares on the Zoom, but if you want to kind of give a wave who you are, thank you for your great mentorship and encouraging the RAs to be here tonight. So in just a minute, I'm going to pass the baton to our RAs, and I'm going to stop talking and let them do the talking to give you a sense of how we're going to structure our time tonight. We're going to hear from 7 of our esteemed students this evening in a series of short presentations. And because we need to, we want to maximize the time for them to share their work before Zoom fatigue sets in for all of us, what I'm going to ask is that everybody just hold your questions until the end of the presentation. And we're going to have set aside time at the end for a Q&A session where you can ask questions to any of the presenters about any of the projects that you hear about. So please don't forget about your questions. Hold on to them, write them down. And we're going to end with some closing remarks and some additional information about the RA program for those of you who might be interested in our RA program for the next 2021-2022 academic year. So with that, I am going to go ahead and pass the baton to our first presenter, who is Laura John Mora, who is going to be presenting about social disability and impairment in childhood anxiety. So I will let Laura go ahead and share her screen and take us away for the evening.
Thank you so much, Dr. Matthews. I really appreciate all the work that you've done to coordinate this symposium. Okay, so before I begin, I really want to thank Dr. Ross for all of her support. Her guidance has been invaluable as I start to develop my own research and scholarship skills. And I also wanted to let you know that in the coming months, we will be also working on an adaptation of the family-based crisis intervention for inpatient psychiatric settings through a grant provided by the American Foundation for Suicide Prevention. with Dr. Ross acting as principal investigator. This evening, however, I will be presenting on our current project, which is an update of a chapter on social disability and impairment in childhood anxiety that was originally written in 2011 by Dr. Muroff and Dr. Ross for the Handbook of Child and Adolescent Anxiety Disorders. So this chapter discusses both the scope and manifestation of anxiety disorder specific social impairment in children and adolescents. It was originally meant to broaden the reader's understanding of anxiety disorders and also to improve assessment, case conceptualization, and treatment plans. So basically, just to give you an idea of the importance of this particular topic and what it does to individuals functioning when they're dealing with anxiety, I think most of us know it leads to a range of difficulties with normal activities, such as interacting with others, going to school or work, attending social gatherings and parties, just starting conversations, even making friends, dating. And social disability and impairment is defined as an absence of normal adaptation related to school performance, a range of developmentally appropriate self-fulfillment activities, and some of those interpersonal performance factors that I just mentioned with family, peers, and potential romantic partners. Evidence from a range of studies suggests that anxiety disorders are actually the most common mental disorders in children and adolescents. And the current data on anxiety among children and adolescents further highlights the importance of research in this domain. Unfortunately, anxiety rates have increased since the last version of this chapter was published. According to the National Institutes of Health, nearly 1 in 3 adolescents ages 13 to 18 will experience an anxiety disorder. And if you look at the graph that I provided, unfortunately, there is also an issue with treatment. So only about 6 in 10 children ages 3 to 17 years old with anxiety actually receive treatment. Research also indicates that female children are about twice as likely as male children to develop each of the anxiety disorders. The structure of the original chapter was to go through all of the disorders and provide a very in-depth description of impairments associated with each of those disorders, as well as the prevalence of each of those anxiety disorders. The limitations that were identified in that original chapter were that a number of assessment tools for childhood anxiety disorders had been developed, and these assessments did not focus specifically on social impairment and did not specifically distinguish between different anxiety disorders. Also, disability and impairment is not only an anxiety disorder specific issue, it's also associated with subthreshold levels of anxiety as well. I won't read off all of the assessment tools, but you can take a look at them on the screen. And then we identified some limitations of the 2011 version of this chapter to work on. And so that was that there was primarily one of the main issues was that there was a relatively limited focus on treatment. And that was due to the lack of literature examining treatments where social disability is measured. We also noticed that although there was mention of subthreshold anxiety, there wasn't a lot of information included on symptomatology. We also noticed that ADHD and ASD with anxiety were not discussed in detail. And very importantly, social and cultural factors related to anxiety and impairment were not explored, including race and racism. As we work on updating the chapter now, we are focusing on comorbidities such as ASD and ADHD. We're focusing on studies of evidence-based treatments currently available, CBT, social skills training, universal school-based interventions, et cetera, and their efficacy in reducing social disability. We're excited to be focusing on the impact of environment-specific considerations and societal stressors as well that may contribute to social disability and impairment, and potential cultural adaptations for these interventions that address these issues. Now, we all know the COVID-19 pandemic has had an enormous impact on everyone's mental health, and it has created a whole series of challenges, one of those being transitioning back into in-person school the disproportionate impact that it had on certain communities. And as of right now, we don't have enough evidence on the impact of COVID yet. What we do know is that youth ages 11 to 17 have been found to be more likely than any other age group to score for moderate to severe symptoms of anxiety and depression throughout the pandemic. We also want to consider developmental stages when assessing impairment, given that a child's level of functioning in this domain may be appropriate at certain ages, but not at others. And social isolation may have actually impacted development of social skills. When we were looking at how to process all this information and what was important, we also wanted to focus on poverty and access to healthcare, as well as quality of the healthcare provided. Family and community factors are often associated with mental, behavioral, and developmental disorders in children. And rates of mental, behavioral, and developmental disorders are higher for children in lower income households. Also, a lower percentage of children in lower income households receive the treatment they need. Historically, most studies on anxiety disorders in children and adolescents have failed to acknowledge the complexity of race and cultural variables that may influence development of disorders, diagnosis, and treatment. And when studies do report racial differences in prevalence, the majority treat racial and ethnic populations as monolithic groups. And variation in social disability and impairment is rarely, if ever, reported. While measurements of social disability and impairment are still rare in anxiety disorder treatment, we're hoping that future research will include these measures in order to really understand the scope of the problem. Research must also elucidate the ways in which societal phenomena, such as the pandemic, institutional racism, et cetera, contribute to what we currently define as social disability and impairment in children and youth. Racial and ethnic groups are not homogeneous. Future studies must examine rates of anxiety disorders and social impairment specifically across subgroups and within the context of these phenomena. Immigrant families are also an important area to research. We need to focus on the impact that acculturative stress, which is stress caused by adjusting to new cultural environments, has on the development of psychopathology. Prevention is also very understudied, so that's a missed opportunity as well. And just to kind of wrap it up, because I know we have maybe 5 to 7 minutes per presenter, I just wanted to give you guys kind of an idea of the timeline of the project. We started the literature review in January. In May, we're going to be completing the draft and circulating it to the co-authors. And then in June, we'll have the final version submitted to editors. And then I just provided a little citation of what it will look like once it's done. And I'll pass it over to our next presenter, who is Danielle. I don't want to mispronounce your name. Danielle Gallus?
Yep, you got it. Hi, everyone. My name's Danielle Gallus, and I've been having the pleasure of working with Dr. Elizabeth Matthews, and I also Dr. Yara Zeisman Alani from Temple University. They have been the greatest mentors, and I can't thank you enough for everything you have done for me and taught me. And the topic for today is optimizing shared decision-making in depression treatment for underserved populations and evaluation of needs and barriers. So we all know that depression is a prevalent issue, and depression affects about 8% of adults aged 20 and over and is a leading cause of disability worldwide. And despite efficacious treatment options, less than 35% initiate treatment, particularly those from disadvantaged or underserved populations. So just to define shared decision-making, it's a health communication approach in which the patient and doctor collaborate to personalize healthcare decisions. And SEM practices can aid in patient participation with their care, and which in turn can provide better outcomes for their patients when their desires are being heard and met. So in turn, a greater understanding of how patients of underserved communities define shared decision-making is needed in order to enhance this practice in depression care. Sorry about that. So there are small numbers of studies that have examined shared decision-making interventions, especially the outcomes of patients with depression, and even less is known about the desires of underserved populations when it comes to communication preferences and decision-making processes. So we want to ask, how do patients of ethnically diverse backgrounds define optimal shared decision-making practices for depression care? So the research methods we utilize is a mixed method study, which recruited participants from primary care practices within a large urban safety net hospital serving one of the poorest catchment areas of Philadelphia, Pennsylvania. Eligible participants were 18 years or over with a diagnosis of depressive disorder and were recruited over the phone to participate in an interview, which was conducted either over the phone or Zoom due to COVID. And then the interview was an in-depth and semi-structured interview that probed for patients' communication preferences, which included decision-making processes around their depression care. So the way we utilize data analysis, all the interviews were transcribed verbatim and uploaded into a qualitative analysis software. The coding and analysis was carried out by a process of inductive thematic analysis. And the core component of this was constant comparative method, where similarities and differences between and within codes are examined in order to identify and refine key emergent themes to use for coding the remaining transcripts. So Elizabeth Matthews and I were the ones that went back and forth comparing to make sure we had a refined code book, to make sure that the emergent themes were refined enough that validity was established. So strategies for rigor, as mentioned before, data triangulation, peer debriefing, and consensus building, memo writing, and an auto trail. Memo writing was also utilized to clarify and making meaning of these emergent themes surrounding how decisions were made in their depression care of each participant and their communication preferences. So the findings, we found that there were 27 participants and the majority showed high preference for routine control over their depression care, majority meaning probably all of them. And then, so stigma associated with depression increased participants' sensitivity of being judged, labeled, or cursed by their providers, thus impacting their initial openness towards treatment. I provided quotes below just to further show you how these statements were very prevalent in seeing these precursors that we need in order to establish shared decision-making and depression care. So the two most important ones, trust and being treated as human meaning being treated beyond the diagnosis, the doctor actually making an effort to make a collaborative relationship with the patient. So that needs to be established prior to shared decision-making in order to enable honest and open collaboration when making decisions about the patient's care. And I'm just going to leave this for just a minute, just in case you wanted to look at the quotes. Just for time's sake, I'm not going to leave it up for too long. All right. Sorry, I would leave this up for longer, but time. So conclusions and implications. So as mentioned before, a high level of trust is valuable and necessary for proper shared decision making processes. And providers need to be aware of the internalized stigma associated with depression that can result in patients' lack of disclosure of symptoms. Providers are encouraged to share their role as expert with patients while establishing a safe and non-judgmental space for their patients. Meaning the patients are experts of their own experience and their symptoms. So the role of expert has to be shared. Providers' expertise in medical field and their knowledge of depression medically, while listening to the patients, because they are the only ones that know their symptoms, they know their experience, they know their preferences, they know what direction they want to go for their care. So prior models of shared decision making have not included these relationship building factors that are necessary precursors for effective collaborative practices. So in turn, now exploring this, maybe more primary care providers can utilize shared decision-making practices in order to make optimal depression care for their patients. And I'm gonna pass this along to the next presenter. Thank you all so much. I really appreciate it.
Thank you for that, Danielle. Hi, my name is Melinda Eberly. I am an MSW student, then I worked with Dr. Farmer this year. So I'm going to share my screen. We did a interdisciplinary study of East Harlem's Little Sisters of the Assumption. And we really looked at mutuality as a catalyst for social change. Since it was a historical study, we wanted to see what was it that made Little Sisters of the Assumption so special over the years, and it has grown from a very small organization into a large one. One of the original sisters wrote an article on mutuality, and so that as we did our study, that obviously came out as one of the common themes. So we'll be looking at the background and the research methods, findings, and then the conclusion. So LSA has been committed to an overall approach based on what they call mutuality, or a power with relational model of care. And they really wanted to look at how working together with mutual respect and an awareness of the dignity and worth of an individual could actually change the person's experience with immigrants moving into this country in East Harlem at that time. And so our study focused on the question of how has these practices of mutuality really built these partnerships with families and the community and helped it to grow. So this is one of the buildings that they used and the new building that they have now. I have a little video clip here that I'll share.
From the beginning, LSA had a vision that the inherent strength of families is a bedrock on which to build. Today, we offer a broad range of healthcare, social services, education, advocacy, and crisis counseling services to hundreds of the most vulnerable families in the East Harlem community. We work with the poorest families who have the least access to the basic necessities of life. No family or individual is ever turned away because of an inability to pay.
So that was a little history on the organization that we were looking at. And it really was a collaboration between the School of Arts and Sciences and the School of Social Services. We had Dr. Brenna Moore, Dr. Carrie Caston, and also Dr. Larry Farmer, who was my supervisor for this year. So we did a qualitative study, including interviews of staff and 40 of the families that worked with LSA, and it was really interesting to hear the history of how the organization came to be, and then also the impact that each of the families experienced. And it wasn't just, you know, a single family unit that was impacted. It was actually several generations of the families as well. And so when we were looking at the interviews, we pulled everything together, and then we did our data analysis to find the common themes. Mutuality became a big one. And then also their three-phase model that they used really was a testament to their success because they put it to work, and a lot of people were able to benefit from it. The three-phase model being providing access to the families to services, whether it be nursing or food services, and also getting kids into school and things like that, or kids into college. So providing access and then educating them on the things that they were going to need for a healthy life. And then the third phase being training them to teach others. And so they really were duplicating themselves by using this model. Our conclusion and implication was that we, because of the longevity of LSA, they started as early as in the 1800s when a few nuns first came into the United States, and they're still here to this day and they're thriving. And so our conclusion was, that this mutuality in the three-phase model, because of the way it replicates itself, that it can be a catalyst for social change well into the future. And that is my presentation. Thank you so much.
Hi, everyone. I'm really excited to share with you a project that I have been involved in with my faculty mentor, Dr. Marciana Popescu. And our project is looking at access to health care and mental health care for women asylum seekers in New York City. This is my outline. I'm not going to go into it since for the sake of time. So that's what I intend to cover in 5 to 7 minutes. Just some quick background. So asylum seekers are considered forcibly displaced people. It's important to keep in mind that they are people who have been forced to leave their country of origin, whether that's due to war or natural disaster, gender-based violence, etc. There are currently 80 million forcibly displaced people worldwide. 4.2 million of those are asylum seekers, and 3.6 million are Venezuelans who have been displaced abroad. We know that forced migration affects women's health and mental health differently. So female migrants experience higher rates of depression, anxiety, PTSD, and higher rates of maternal mortality, premature birth, and perinatal mental health disorders than male migrants and non-migrants of all genders. And the reasons for that are layered and complex. And I've had this graph here with, well, it's a chart with pre-migration, during migration, and post-migration factors that sort of combine to make these health outcomes more negative for these women. But I'm not going to go into depth with this because I want you to see it in our data. So our project asks 2 questions. And the first is, what are the specific health issues and barriers to health access that female asylum seekers face in New York City? And how can we work together to improve their access to health and mental health care? And the word together is very important here for two reasons. The first is that there's a whole team of us on this project, and the most important team members are 10 female asylum seekers, we call them activists, from Venezuela, Burkina Faso, Ivory Coast, Nigeria, and Russia. And we also have partner organizations here in New York City that work with asylum seekers and immigrants. And the other reason the word together is important is because of the methods that we're using in this project. We're using a method called merging of knowledge, which originated with anti-poverty research. But if you're familiar with participatory action research, it's essentially in that vein. So it involves directly engaging with the experiences of people who have directly experienced the issue under study. And it merges the knowledge of 3 groups. In our case, we are merging the knowledge of people who directly experience asylum, professionals. One part of our project will be to engage with healthcare providers, and academics, which is our team at Fordham. So we all come together and we have discussion and dialogue. And we also have teams for different parts of our project, and those teams consist of both asylum seekers and students who work together on a particular aspect of the project. So about 2 to 3 weeks ago, we sat down for the first time to look over the notes that have been taken during our discussions, and we worked together to pick out some of the main themes that emerged during our discussions, which I've mapped out here. So I tried to keep sort of similar themes together, and we're still in the process of doing our qualitative data analysis. So this is just what we have so far. You can see that lack of access to information, lack of support, difficulty accessing care, need for reliable sources of information, is very important. And there's also very gender specific experiences that the women have talked about. Vulnerability of women, intimate partner violence, gender-based violence. And they also talked about the importance of having gender-specific support and the importance of women coming together and collaborating. And so I just want to show how these themes map on to what the women have said. I'm not going to read these to you because you can read them yourself, but in the first one, we see a woman who went to the hospital and had such a, this experience, felt like she couldn't ask questions. She wasn't being consistently informed about what was happening to her, about the care that she was receiving, and this led to fear and mistrust. In the second one, this woman expressed how important it is just to have access to information. And it's not just information about what healthcare is available or just knowing where to go. It's also about your rights. What rights do you have as an asylum seeker? And not having that it leads to a sense of disempowerment, and it leads to a feeling of not being safe. In these statements, the first one, we have a woman who recalled her experience when she first came to the United States, and she was living in a homeless shelter, which is a place not specifically designed for asylum seekers, not quite attuned to their needs. And it's a place where their information was not protected. And in this case, she felt vulnerable and unsafe. And there was the experience of another asylum seeker in this shelter who had been sexually assaulted. In the second statement, this woman talks about a specific instance of violence. This one is between a mother and a son. And in this case, lack of money and financial instability was a factor that led to the violence. And this statement also touches on the feelings of depression and suicidality, which is something else that is emerging in our discussions. So there are 3 intended outputs for our project. The first one is that we are creating a website and an app that will gather data on healthcare challenges and provide access to personalized information based on what the person inputs when they're going through the website. And this will connect them to resources, policies, and information on their rights. We also, and the purpose of that is capacity building, sort of putting the information into these women's hands so that they can claim their rights. The second one is we're going to create a training curriculum that's going to be led by the women themselves. And this is going to be a training for healthcare service providers. And the objective is to improve the ability of service providers to meet the specific health and mental health care needs of asylum seekers. And our third intended output is to create asylum seekers informed policy recommendations so that we can improve their access to health and mental health care services. And I wanted to share this statement that I think really embodies the impact that our outputs can have and the impact that healthcare service providers and doctors can have on this community when they're aware of the type of environments that these women need. This particular woman recalled her experience at Bellevue Hospital, and she said that when she was there, there was a sign that said, "We do not care about your status, we care about your health." And seeing that helped her to feel safe and, created the sense that she was in a safe place. And it's something so simple where it's just a simple use of language can make someone feel safe in a given space. But these are the sort of things that we can speak to healthcare providers about to help create an environment that's responsive to their needs. And I will leave it there. And I will pass this on to Simone.
Good evening, everyone. Let me share my screen. So today I wanted to present on community health workers and the impact they have within their communities and the implications of this rising profession. A special thank you to my faculty mentor, Dr. Rabel Rahman, who I've been working with since the beginning of last year, September, and this has been definitely a project in the making from September until now. So a little bit of background. The study examines community health workers hired through New York State maternal and infant child healthcare program. So the research question that was targeted was, what is the missing link in community health worker professional development? So to start working on the manuscript, I conducted literature reviews on the perception of community health workers and their role in healthcare. So studying executive directors and supervisors' view on organizational and policy level challenges faced by community health workers was the manuscript worked on, led by Dr. Rahman, and contributed literature reviews also. And this is a manuscript for the Journal of Ambulatory Care Management. So the presentation will focus on key points from the literature review. The methods used were mixed. So for qualitative study, we did focus groups with 7 executive directors and 6 supervisors of community health workers. And then for the quantitative side of the methods, 75 community health workers were surveyed. So through literature review, the findings were that community health workers are frontline public health workers who often are members of the community that they serve, and they often share the same lived experiences through language, culture, socioeconomic needs in the community that they serve. It has been founded that community health workers were very valuable in linking family and basic survival skills, and are essential to linking clients to appropriate services. So community health workers who work within their community are working within neighborhoods, homes, schools, work sites, so on and so forth, but most importantly within health settings, health departments, clinics, and hospitals. In 2010, the Department of Labor identified and formally recognized them as a very integral part of the labor profession. But despite the recognition that community health workers got for their role and their abilities to help their communities and help those underserved, executive directors reported a lack of funding and budgets and that's what caused, one of the reasons that caused a high turnover rate among community health workers. So most EDs reported that their community health workers earn between $24,000 to $32,000 annually. And majority of the funding for community health workers was temporary funding that only lasted 3 to 5 years. So with that being said, where majority of funding for community health workers was temporary, there's very, very few organizations that hire community health workers directly, and community health workers are established within interdisciplinary teams. So continued findings in 2019, the United States Bureau of Labor estimated that currently there's 58,950 community health workers employed in the US. And specifically in the state of New York, they have the highest employment number of 6,590. Overall employment of community health workers is projected to grow by 13% between 2019 to 2029, which is a very fast growing occupation. So within this study, it was found that community health workers within their communities, neighborhoods, and local healthcare settings, they have seen success in reducing health disparities, incident rates with HIV and AIDS, malaria, and even emergency department visits. And they're also known to increase immunization, cancer screenings, management of asthma, diabetes, and even insurance enrollment. So in conclusion, with the implications of community health profession, it is seen that professionalism is a big part of hiring and onboarding processes. And for those who work within their community and those who come from the same community as the people that they serve, they show that there is a lack of professionalism. So dressing and arriving on to interviews on time, the ability to draw boundaries when it comes to self-disclosure with clients, and also knowledge in completing documentation. And that further goes down to inadequate training and infrastructure. So there's a lack of training and there's a lack of understanding for very sensitive trainings like CDC trainings and HIPAA and confidentiality, and even mandating reporting services, which makes it hard for community health workers to find a foundation within bigger health professions and interdisciplinary teams. So a couple solutions for these implications, we would like to see develop community health worker specific coalitions. These coalitions to advocate for more funding and for permanent positions for community health workers, and to develop legislative agendas that will help find adequate funding for the field. And also lastly, with professional development, working in healthcare and public health, it is very important to assess and to do performance reviews on engaging diversity and difference in practices and human rights and social rights, and also assessment and termination tools that will also be needed in community healthcare work. So I will pass this on to Michael.
Thanks, Simone. Hi, everyone. Just going to share my screen. And before anything, just want to take the time to thank Fordham for doing this symposium, and thank the professor that I've been doing research with, Dr. Jordan Delphiler. So basically, the presentation I'm going to be doing isn't your traditional presentation, so like won't have the introduction, methods, stuff like that. Instead, we were asked to write a review on police violence and public health, and I've been assisting in the process. So just a couple of things to keep in mind when it comes to police violence. And some of you may be aware of this, some of you may not. Yes, it's true in the past several decades, a growing amount of attention has obviously been given on police violence. However, data on police violence has not been systematically organized or and obtained by US police departments, right? There's no universal database or national database that's shared among all police departments. So it's really complicated when it comes to finding how many fatalities occur each year and stuff like that. Further complicating this matter is the fact that research examining the effect of police violence has on mental health has been limited. So as I said, the presentation will not follow traditional with the format. So just very quickly, definition of police violence, It's a pretty elusive concept. What is police violence? For the purpose of this presentation, we define police violence as physical or psychological injuries or fatality due to excessive maltreatment, abuse, or neglect. And research has repeatedly shown that people of color are more likely to die in police custody. It should also be noted that the history of the police, it's a complex one. So for instance, slave patrols that were formed in the 1700s have been arguably seen as the first publicly funded police department in the South of colonial America, and their responsibilities included disbanding organized meetings among slaves and catching runaway slaves. Scholars have also argued that throughout US history, the police has been used to maintain control of minority populations, including populations residing in regions America colonized. So there's actually really good literature on stuff like how police was used when it comes to maintaining control in areas like Guam. In regards to the literature review, we reviewed literature that examined the relationship between police violence and physical or mental health outcomes. As previously noted, we were working with a small sample of studies, but major findings worth noting were as follows: negative encounters with police, right, experience of aggressive stops and invasive searches were all associated with greater anxiety symptoms, depressive symptoms, and overall self-reported reduced quality of life. Lifetime police violence exposure was gradually correlated to depressive symptoms, psychotic experience, and suicide ideation. And these findings were much more pronounced in the Hispanic and African American populations. And there are several different solutions that have been proposed when it comes to reducing or alleviating police violence. One is having federal prosecutors investigate police misconduct, as they are less reliant on preserving good relationships with the local police. Another is ending qualified immunity for police officers. There's actually a bill right now up in the Senate regarding that, where police officers, right, they're currently immune from being sued for abuse of power, misconduct, unless a court previously ruled that it was clearly established that the police officer's precise actions were unconstitutional. It's kind of a fancy way of just saying that it's very difficult to sue police officers because you really need precedent set exactly on their specific actions. Reduction of the ways in which the police force has been militarized is also another potential solution. Creating more diverse police departments has also been proposed. Enhanced training and implicit bias and de-escalation tactics have also been proposed. Greater emphasis on community policing, which is a term that I think a lot of us, especially in New York, have heard often, right? That is kind of referring to increased outreach and communication between police and the community they patrol, as well as lastly, reducing our reliance on the use of police to address various situations and gradual abolition, which seems to become more popular concept in the last couple of years. One thing worth mentioning is, even though it's very popular with body cameras, I think it's worth noting that a lot of research has shown that requiring police to wear body cameras doesn't seem to really reduce the amount of violence. Where we go from here, right, there are both positives and drawbacks that would come from each solution. I'm not going to go into each one due to the length of time. Unfortunately, the decentralization of the police also makes both studying the police and implementing broad changes quite difficult. We recommend, for instance, a national database of violent incidents involving the police, right, as it does not currently exist, right, that it needs to be created. In addition, scientific research examining the effectiveness of possible solutions has been limited, right? Thus, research on police violence must rapidly expand to ensure that the strategies we implement will be effective. So a lot of the policies that people have proposed, there's not really a lot of research on these policies if they're actually going to work or not. And these are just my references. Thank you everyone for listening. I am now going to pass it on to Rena.
Hi everyone, thank you for being here. I'm going to share my screen now. Okay, so my name is Rena Goldstein. I'm a second-year grad student here. I've had the opportunity to work with Dr. Jordan DeVilder, as well as Dr. Deidre England of City College. My research interest pertains to mental health care, early intervention, and preventative efforts. And so I got lucky enough to work on this project of suicide stigma and suicidality in young adults in the US. So just for some background, we know that suicide is a leading cause of death in young adults in the US and that the numbers have risen. There is an increasing effort to identify suicidality using various screening tools. However, these screening tools can pose the risk of having people feel stigmatized while they're used. And we know that stigma is a known risk factor for suicidal behavior and other negative mental health outcomes. So you can see here in this little diagram where you have the visit to a healthcare provider at the beginning of the year. And then by the end of the year, often young adults will die by suicide, sometimes even within the weeks after having visited a healthcare provider. During that visit, we have the potential to screen for suicide. However, there are the risks of internalized stigma, like I mentioned. And so screening has to be done carefully. So while it's a good idea, we have to eliminate the effects of the stigma and ensure its safe implementation. So to summarize the research questions, we want to know whether stigma is perceived differently by those with suicidal ideation as opposed to those, with general mental health concerns. And if so, what are the specific impacts of suicide stigma specifically on this population? And how can these impacts be addressed in suicide prevention efforts? So it's important to understand how stigma is perceived and internalized, and to recognize the greatest areas of impacts that need to be addressed. And the significance of this study is that it will tell us if stigma is a substantial concern, and whether or not it's a concern during screenings, which can pose a tremendous risk. So for the research methods, we will be, we were measuring these three constructs: stereotype awareness, which is the awareness of the general stereotype, and then the agreement, which is an internalized stigma and sometimes sort of a self-fulfilling prophecy, and then emotional disclosure. So we had a sample of 14,147 students who had previously participated in the Healthy Minds study and were willing to participate in this project and provide their information. Our measures were standardized scales to compare the above three constructs to mental health outcomes, as you'll see in the next slide. And the analysis, we used an ANOVA test to compare the different measures. So as you can see on this chart here, we have the three constructs down the side: the emotional disclosure, perceived stigma, and personal stigma. And we compared those to measures of suicide attempts, self-harm, severe depression, severe anxiety, and then on the positive end, flourishing. And the results are presented as an odds ratio. So any numbers there that you see that are above 1.0 means that there was an increase in that measure, and any beneath that means there was a decrease in that measure. And so to summarize what this chart is saying is that the greater stigma contributed to increased depression, anxiety, self-harm, and the likelihood of attempts, whereas the association with psychological flourishing was negative, which essentially just means that the greater the stigma, the worse the outcomes. So for the findings, we have stigma is associated with the greater likelihood of suicide attempts, depression, and anxiety among college students with suicidal ideation. However, it may be modifiable, and a lesser stigma could potentially alleviate the negative side of suicide risk screening. By doing this, we can increase access to care in a safe way. And so for the conclusions and implications, we've seen that prior research has found that higher levels of mental illness or suicide-related literacy can actually decrease stigma. So we propose that providing mental health literacy in areas that can be accessed easily by this population can be of help, as well as measures such as higher education, increased peer services, increased contact with those who've experienced or are currently experiencing suicidal ideation, advocacy, and policy changes. The study provides sufficient evidence of elevated experiences of stigma among youth with suicidal ideation and associations between stigma and the negative mental health outcomes that you've seen on the chart. And this warrants future research and investigations so that proper services can be provided to eliminate stigma and to increase success rates of suicide screening and interventions safely. And thank you all for being here and for listening. And thank you, Dr. Matthews, for arranging this symposium.
Thank you all for those presentations. Before we move on, if I can ask everybody that's here to just unmute for 1 second and give a round of applause so that they can all hear to these amazing presentations.
Very nice. Nice job. Great job.
Very well done.
Great job,
Excellent.
everybody.
Excellent.
I know this is not the same as a round of applause in a real audience, but these were all exceptional presentations and a great reflection of the work you all did. With that, because there were so many different topics covered, timely topics covered, and I know you have a lot more to say about all the research you did. I must say that second only to how impressed I am with all the work you did is the fact that you were so timely on wrapping up your presentations. And I think I need to take notes from all of you as I talk for ages longer than I'm supposed to. So props for that as well. And excited that we have more time to continue talking about your work. So I am I think our group is of a size where folks can kind of pipe in and unmute yourself. Also, feel free to enter questions into the chat that I can pose to the group, but I'm just going to open it up now and let folks ask any questions they had to any of the presenters that you heard.
So this is for Ms. Adler. Of the three groups that you mentioned, you said that the women would have access to health professionals. And I was wondering if that was mental health professionals or physical health, medical health professionals, or both, or a combination.
Yeah, that's a good question. I believe it's both. We haven't gotten to that. Yeah, it's both. We haven't gotten to that stage yet, but it will be both. Yes.
Thank you.
If I can just interject, the idea is we want to increase access to healthcare and mental health care, because we have a gender lens. We will focus on reproductive healthcare and mental health care in particular, but all kinds of services that women are deciding are important will be included.
Thank you.
Okay, I'd like to jump in with a quick question for Laura on the chapter on anxiety for adolescents. I was wondering, during that time, did you run across literature with social media and anxiety? Is that something that might be looked at down the line as it pertains to adolescents?
Yeah, there's definitely a lot of literature on the effect of social media. We haven't talked about whether we want to include that yet or not, but that's an interesting point, and it's definitely something that I did find a lot of literature on.
If you don't mind, I want to also add, I've been here at Fordham since 1999, and this really I teach research. This really is a wonderful thing, Dr. Matthews. I'm so glad you have this started. This is really great. Just want to say nice job, everybody.
Well, I will jump in with a question, and this is kind of posed to all of the presenters, and I'd love to hear from a few of you, anyone that wants to chime in. I'm just interested to hear kind of more generally, as you engaged in research and learned a lot about these topics, what either surprised you that you learned or has really kind of resonated with you about some of the data you collected and findings that you gleaned from your work.
I can go first. Just the whole topic in general, I've never heard of the community health worker profession. So to really just dive deep into a different realm of public health and healthcare, knowing that it's not just a nationwide rising profession, but it's a profession that's really emerging across all nations, and that it's a new way of reaching those who are underserved and who don't know the basics of what's important when it comes to their health and their rights to healthcare. So it's been a whole learning experience.
I think I've learned that sometimes I can only speak for myself, but I assume that there are easy solutions to questions. And then through the research, you recognize that there really are so many different implications and complications. And I guess, through our research, just recognizing that it seems like a quick fix where you have, people who die by suicide within a year of seeing their health providers, you would think the quick fix is to just have screening across the board always. But then through the research, we've come to recognize how the stigma of the screening can be so harmful. So I think that that was just something that stood out to me, that sometimes those very obvious answers aren't necessarily the correct answers.
Yeah, mine is just a very, very specific one, but I was surprised that there wasn't more research already done on social impairment in populations that are not children with ASD. So I thought it was interesting that there wasn't a lot more already, out there on anxiety and specific types of anxiety and how that translates into social impairment. Besides, obviously, social anxiety disorder, there is, that there is some on that, but there isn't enough really. So I thought that was interesting.
One of the things I learned in our project was that it can be something very simple that makes significant change and significant impact. So like with the mutuality and the three-phase model of the Little Sisters of the Assumption, like it sounds complicated, but it's really just relationship building and providing access and resources so that they can, give that to someone else. And how that very simple process has really impacted the community around them. And they started with, I think it was like 4 sisters, and now it's like a huge organization. I looked at one of their budgets, it was like $500 million or something like that. Maybe I'm wrong, but that's what I remember the number being. Anyway, and so I just was like, they went from something so small to something so large with a very simple, reproducible model. So that was cool.
I guess I'll go. So for the record, it's weird with Zoom. It's still like this weird free for all. Whoever speaks first. Anyway, I guess what I learned, and this is, very specific, but I was really surprised how limited the literature is when it comes to police violence. Despite the amount of attention the media gives it, the research really is still lacking. And you're talking about, incidents that, there are famous incidents that you can go back to in the 1990s, the 1960s, and so forth. But yet the research really just is non-existent. So I was kind of really surprised by that. I mean, it makes sense to an extent. Obviously, there are going to be certain powers that are reluctant for change or for, studies to occur. But I was still surprised that there wasn't more out there.
I think I see a question from Elizabeth, if any of the other presenters want to jump in with any other lessons learned or interesting, and then if not, we can go towards your question, Elizabeth.
I just wanted to say that, before we started, I just always knew of client-centered care, but now going into more shared decision-making, I feel like it would be such a great tool to use, especially in depression care, because they already feel like they lost their autonomy. So that kind of just gives it back to them while helping, while collaborating with the doctor, because some primary care doctors do kind of try to take control. And I feel it's a topic that needs more attention, and definitely, and I was surprised to hear that and see that there's a little bit of research on it, but I'm glad to be a part of the research that I discussed.
And just really quick, I think for me, one of the most impactful parts of this project is being able to directly engage with female asylum seekers. Reading about it is one thing, but hearing their experiences from their mouths is so impactful. And I think we need to hear more from the people who are experiencing this, because reading it is not even comparable. So
yeah, thank you all for sharing. I think we got everybody. I apologize if not, but I know I saw a hand from Elizabeth Hernandez, if you wanted to
Yes.
ask a question as well.
Hi, thank you. My question was for Michael. I was also impressed about the small or little to none research on police violence, especially that is a topic that has always been, how would I say, on the table, and it has increased the problematic with the police violence. You did mention there will be some training for police officers for training to de-escalate, to learn how to de-escalate a problem. Do you think that in the future there will also be a training teaching police about cultural competence and cultural diversity, given that in order to also decrease how police officers view minorities, the underserved population, and so on, so forth. Would there be like a policy created to train them and give them information on cultural differences and possibly how to minimize those biases and prejudices that they experience just as everyone?
So yeah, I mean, one of the issues is like there's no like national policy that could be, you know, implemented just because it's so decentralized at this moment. But there are definitely police departments that have embraced or are starting to embrace more diversity training, similar when it comes to implicit bias training and learning more about the cultures, various cultures that aren't their own. One of the interesting things is, you know, obviously the research is again limited, but you know, the studies again don't like produce the most clear results. And one thing that a lot of people have also proposed is creating more diverse police departments, right? Making it where the community looks more like the police and vice versa. And that also the results haven't been as promising as certain people would have thought.
I understand. I see the point of creating a more police departments that have more diversity. But many times I can tell you that within our own culture, we have biases and prejudices towards people from our own culture. So I think that possibly if there is some training on, I mean, you cannot eliminate, you cannot, or let's say, you cannot force a person to eliminate their biases or their prejudice, but you can help them to be knowledgeable about it and see if that can help them to be more empathetic to the people that they will serve in the community where they work.
Oh yeah, no, I definitely agree. I mean, I find it interesting that social workers, you know, I feel like there's such a more proactive approach when it comes to embracing cultural competence and understanding where your clients are coming from. And yet police who, you know, have a very, you know, significant job, it doesn't seem to yet be as emphasized. Yeah, I think it can go a long way.
Interesting, thank you.
If I could just jump in and make a point on that real quick too. Michael
Sure.
made a great point about the need for a federal database and mandated reporting for more precincts. If you don't have the data, you don't know what's going on. So very often we begin to create programs and solutions when in fact we don't have all the data to begin with. So that first step of getting you know, all jurisdictions to report, mandated reporting on a federal database would be a really critical first step.
I agree. Yes, I also have another question. This question is addressed to Ms. Adler and Professor Popescu. Talking about the police, are there any invitations to train police officers how to recognize asylum seekers? And also because asylum seekers during forced migration, they come with such harsh experiences from their countries. Many are even afraid to approach police officers to ask for help. Are there any trainings for the police officers to know how to recognize a person that might be afraid to approach them, and also maybe give some type of information to asylum seekers that they can reach out to police officers for help when they see themselves in a situation where they might need to ask for help from a police officers. And given that in many of their countries, they face the authorities that they have over there, they experience that there's a lot of corruption and many abuse from their own authorities. So how can we help asylum seekers to have that confidence to and not have that fear to approach a police officer when they find themselves in danger?
Yeah, so all of that is very true and very good points. Our project is not specifically focused on police, but some of the women have spoken about fear of reporting. So there is that fear, you know, and not knowing what your rights are as an asylum seeker is one of the themes that comes up. So I'm not too sure of what's going on in terms of training police to deal with asylum seekers, so it is definitely needed. And I think it goes both ways. I think police need to be educated about these people, and these people also need to know what their rights are and you know, be able to stand up for themselves too in these types of situations. But that's all I can tell you, because I'm not too familiar with what is out there in terms of policing.
Thank you.
And if I can add just one thing, but as Alison said, you know, some of these themes started emerging, and our whole methodology is extremely participatory. So while we started with a very clear focus on health and mental health, we are listening to the women with lived experiences of forced migration and ask them to educate us. What does it mean to be an asylum seeker in New York City? How do you experience police officers in a time in which, you know, like just last year, people were arrested and deported, and justified as a public health concern, right? So we are working with service providers as well, particularly health and mental health care service providers, but based on where the women will take us, we will look at what else is needed. And while we cannot do it all, we'll try to at least, you know, like provide information on rights and identify resources that women can tap into.
Thank you so much. I think that I saw Jerome's hand go up as well if you had a question, and then I also see yours, Michael, as well.
Yeah, so for Michael, just out of curiosity, did you come across any literature while you were digging that talked about integrating social workers or mental health professionals with the police when they respond to calls, where that might be appropriate? Was there anything out there about that?
Yeah, there's definitely some research out there. I remember mayoral candidate Robert Ganji was very much a proponent of that. I don't know when it comes to what the studies are when it comes to that kind of stuff. I can say there is a certain, you know, and this is anecdotal, but I can say that there is definitely a certain cynicism when it comes to people feeling like social workers will just replace, you know, that it won't solve the structural issues. It will just be surface level change. But I don't know. Jordan, I don't know if you have more extensive knowledge on that.
There's not a lot of formal research on that. You know, this is something that was, you know, has been tried in various places, and now it's I think been kind of suddenly launched into the forefront as a major debate in social work because of, you know, the events of the last few years. And I think there's a split where some in social work feel that, you know, this, you know, having these kind of interdisciplinary teams could be a helpful way to address the issue, and some feel like it's a more structural and systemic issue, and that we need to create alternatives to the current police system as opposed to joining it, essentially. But it's you know, at least from the empirical research side, it's something that we are in need of more data on, I would say.
Thank you both.
Thank you. And Michael, did you have a question you wanted to pose yourself? Had a lot coming your way.
Yeah, so yeah, actually, so this is a little bit of a complex question, maybe. Questions to Rena. I'm kind of curious. Like, I know there's like literature, like there was a certain controversy when it comes to things like 13 Reasons Why and shows like that. I was wondering if there's, you know, certain benefits, like unrealized benefits that maybe, if nothing else, it may be reducing stigma in the media. You know, not maybe that particular show, but the concept of really like media kind of having it where suicide's more normalized, common phenomenon.
Thanks for that question. I actually did a paper some number of years ago, right around that big controversy, specifically about 13 Reasons Why. So I only saw research that was sort of, I guess, against the idea of having that on popular media. However, I did notice that since then, lots of different shows and movies will have resources there. So, you know, they'll begin with like a trigger warning and then say, if you're experiencing whatever symptoms, like, you know, reach out to such and such person. And I think that I haven't seen any research on this, but I think that, you know, just by the fact that they are beginning to like open that up as a topic of, I guess, warning probably does decrease the stigma to some extent, because it's sort of like, we know that there are people out there who are experiencing this. That's just in my personal experience, having, you know, done some research in the past on that and then just recognizing that now. But I haven't seen any literature specifically on that.
And just to add to that, there's you know, pretty good evidence on how different ways of portraying suicide affect population level rates. And there's actually specific media guidelines that are you know, that are put out that are intended to allow the media to report on deaths by suicide in ways that ideally would reduce the number of, you know, the potential negative impact. But you know, when they're not followed, we actually see pretty severe consequences. You know, there have been some cases where celebrities have died by suicide, and there was a famous case in Korea where it was these two you know, two celebrities that in the media published how they did it with like step-by-step instructions and all this stuff, and then the rates using that method went way up. So we know that there is this contagion effect, but there's also ways to counter it depending on how this type of information is portrayed and whether it's seen in like a glorified way or not, and other factors.
Well, thank you, everybody. And thank you for some really great questions. Students, you did an amazing job fielding and responding to all these questions and asking really great questions yourself. So thank you again for all of that. I'm looking at the time and want to wrap us up promptly. So I'm going to close us out with kind of some brief information about the RA program, but really hope to use this platform to just gain more visibility to some of the structures and supports around research that we have at GSS. One of them being the CARS committee, or the Committee for the Advancement of Research and Scholarship, of which I am a part and many of the other faculty here are as well. This year we have been led by Dr. DeWilder, our fearless leader, who will be passing the baton to Dr. Goldkind. So I just want to give her the mic and the stage for a quick second to say hello and give a quick word about CARS before I close us out.
Thanks, Liz. And thanks, Jordan, for creating such a beautiful space. It's really exciting to see so much research going on amongst our master's students at Fordham. I'm Lori Goldkind. I'm the incoming chair of the CARS committee. And I look forward to seeing research across our master's students grow even more. I just have one quick plug for the RA program for next year. It sounds like everybody's done really amazing work. And one of the best recommending strategies, or like the recruitment strategies, is to have you guys go out and tell your class colleagues what a great experience this was. And so the application will open in a few weeks. We look forward to seeing lots of new faces. And I agree with Sebastian. This is my 12th or 13th year at Fordham, and I have never seen such prolific research. It's really, really exciting. And so I look forward to seeing new applicants come forward. And thanks again, you guys. Great work.
Thank you so much, Dr. Goldkind. So kind of building off of that, we do hope that you will go and tell your peers and your classmates about the great work that you're doing and some of the great work that you heard about today, because there is such great research being done all over the place already that we're hoping to really continue and have more opportunities to talk about. So as Dr. Goldkind mentioned, there will be an application opening for the academic year in 2021-2022 for RA programs that will be coming your way in July. So we'll give you a little bit to decompress after this semester before we ask you to think about the next year. So do look out for that. And you can always feel free to reach out with any questions about the RA program. I'm going to go ahead and put my email in the chat as I am typing it right now and not doing a good job of typing and talking, but I have been kind of fielding and organizing the CARS RA program, and I'm happy to help you get connected with faculty and increase any opportunity for you to do research here at GSS while you're here. So this is my email and my name again. And I thank you for being here tonight and for coming. Thank you again to all the presenters. You were phenomenal this evening and have done a great job showcasing how great RA-ship is at GSS with your very impressive presentations. So with that, enjoy the rest of your evening. I look forward to seeing more of you at ongoing research events like this. Thanks again, everybody, and enjoy your night.